I would have liked someone at some point to take me aside and said, let's talk about it. Because I would say that episode that I had first on, that affected me for weeks because I didn't sleep well. I was like a little bit agitated and nervous at work because I didn't want to mess up again. I thought that patient died because of me.
You might think to yourself, oh, I've done this many years of placement. I've worked in London hospitals or whatever. But there's a difference between you being there on placement and you being the responsible clinician. When you're there as a medical student, if anything pops off or if a patient starts to become unwell, then there's always a senior around. I mean, you're not going to be doing anything anyway. You're just going to be there observing. They might get you to help them do something.
And the nurse comes to me and says, this patient's got a temperature, he's tachycardic, his pulse is 180, it's abnormal, he's feeling short of breath, he's got lots of abdominal pain, can you come and see? And I'm like, I don't know if I'm ready for this. Even if you go back, like, I'm not even talking 500 years ago, I'm talking in the early 19th century, Einstein days. Einstein had a ruptured aortic aneurysm. He was suffering from an abdominal aortic aneurysm for years. He had chronic abdominal pain.
Hello and welcome to a brand new episode of the Strive Med podcast. Just to introduce everyone today, this is myself, Dr. Anam, junior doctor, foundation year 2. This is my best friend.
Dr. Zach, also junior doctor, foundation year 2.
And we're both founders of Strive Med, helping any students out there getting into medicine, GCSE tutoring, A-level tutoring. Without further ado, we have a very special guest with us today, Dr. Karan Raj. Thank you so much for coming down.
Thanks for having me, boys.
I guess today needs no further introduction. I'm sure you must have seen him all over your Instagram explore pages, TikTok. You must have seen him somewhere. He's one of the members of the team, our special team we have in the NHS, surgical registrar, putting in the hard shifts, the hard grind. You guys know what's going on in the current climate.
Yes. Yeah, I mean,
the current without the T, that's how people pronounce Dr. Karan's name.
Yeah.
We all know what's going on in the current climate, obviously difficulties with the junior doctor, so he's out there in the trenches with us day in, day out. At the same time, he's built his social media empire, teaching millions. And to be honest, just first things first, I really resonated with your content, and it's gone a long way to inspire me as well. I think a lot of the times, from my point of view, especially when you're putting in the hard yards and the grind, you can end up forgetting the passion which you initially had for the medicine and the medical knowledge, and the way you've managed to combine the two in the form of entertainment, which actually really inspires the youth and makes it interesting for them. That's also amazing. And it really matches with the Strive Med ethos as well, because the very name of Strive Med consists of the word strive, and that shows the reality of working as a doctor. And we're not trying to present the flashbang that may be demonstrated on social media. Things as a doctor, things can get difficult as well. So really resonated with your content. Thank you so much for coming down today.
Yeah, man. I mean, there's nothing further to add to what Inam said, but obviously I'm starstruck, innit? Got Dr. Karan with us, and yeah, just a pleasure, man. Thank you for coming on the pod.
It's good to be here.
I appreciate your time, man.
Good to be here. But, like you said, actually, I won't lie, like probably 2 years ago, mid-pandemic, I was feeling more and more disillusioned than I ever felt before about being in the NHS, being a doctor. And definitely social media gave me that outlet to rediscover almost my passion for medicine, education, learning. Because when you educate and make videos, you learn as well yourself. You got to check that your stuff is accurate. So it's a form of extra learning for yourself. So that gave me an outlet which reignited my passion to, hang on, I'm not ready to quit the NHS and, my work in surgery right now. And it gave me that. So without having the access to social media, maybe I would have walked away, in 2020, 2021, maybe.
Wow.
Yeah.
Exactly. I remember how it was when I first entered med school. I remember I was holding the heart and I was like, okay, this is the aorta. This actually pumps blood throughout the entire body. Is this vessel right here?
Yeah.
And you just have that naive lens and you're just amazed by everything that you see. And then when you're actually like tested in the actual workplace, the test, trial after trial, the day after day, night after night, that can tend to dwindle. But, I think even from having these discussions as well, we feel rejuvenated, reignited, ready to go.
I was gonna say, like, similar to what you touched on about how social media uplifted you. Same with me and Inam. We used to say, like, this podcast, a lot of people think we started it obviously for the people. Obviously, it benefits the viewers as well, it's education for them. But first and foremost, for me and Inam, it's therapy for us.
It is therapy,
Yeah,
it's talking.
it's debriefing.
Yeah. I mean,
it's good.
that's the thing. Like, we don't talk as doctors enough about the trauma, the micro trauma and the macro trauma that we face every day. You know, you start a shift, you might, first thing before handover, you might be running to a crash call.
Yeah.
And then you skip lunch. You know, you hold in, your urine because you're busy doing something.
Yeah.
You get a stressful 4 bleeps in a row, and then you might see a death. You're doing CPR. So just those 5 things, and there's probably more than 5 things going on.
Yeah.
All those stresses, you don't realize it now, but it's just adding burden to your mind. And then at no point, whenever I've had a crash call, anything, I can remember one time when I was doing, like lots of crash calls as an F1, when a senior took me to one side and be like, do you want to talk about it? Otherwise, you just do the crash call and then you carry on your day.
Yeah,
Someone's
it's
died
crazy.
and then you just carry on doing your ward round.
It's a movie, man. It's an actual Hollywood movie, man. Blockbuster.
And
That's
you're like, as an F1, you just seen a death maybe for the first time.
Yeah.
And you're like, I'll be honest with you. When I did my first ever crash call as a doctor, it was in my 2nd or 3rd day on an elderly care ward, like my mind went blank. And I was just like almost being told what to do by the nurses. Okay, do CPR, do this, do that. Patient passed away and I felt guilty. You know, you have this kind of guilt. I think everyone goes through it. When you lose a patient, you kind of think, could I have done anything better? Is it my fault? And I would have liked someone at some point to take me aside and said, let's talk about it. Because I would say that episode that I had first on, that affected me for weeks because I didn't sleep well. I was like a little bit agitated and nervous at work because I didn't want to mess up again. I thought that patient died because of me. But, they were probably going to die anyway. I think, I was just involved at the later stage when I was doing CPR and everyone else was involved. I hadn't met the patient before. But you internalize that guilt. And we need more of these kind of debriefs and chats being open and honest about it.
Yeah, agreed, man. 100%, bro. And that's the same thing, me and Inam. Because before this, what we used to do is we used to call each other. So I'd finish a 12-hour on-call shift, and like instantly you need to speak to someone, man. Because if you bottle that up and you internalize it, you keep it in, it may not break you the first day, nor the second day, but the 3rd and 4th day, you'll start, experiencing burnout. You start crumbling, you start performing poorly at work, and it's not effective. So I think this is something that, is underrated, and I don't think a lot of doctors do it. A lot of healthcare professionals don't do it. And for us, we're just fortunate enough to have a podcast platform where we can not only share those thoughts with other people, but also ourselves. We can like have that debrief and discuss and, learn from mistakes or anything and reflect on various points in our career.
But what's happened now, the problem in the NHS right now, I mean, let's ignore the working conditions and ignore the pay. I mean, that's a whole can of worms, which that's a whole other podcast talking about that. But, back in the day, so the consultants that we work for now, or the senior consultants, they used to work in a system where it was a firm culture, where the same group of doctors would be working the same shifts all the time.
Wow.
So in that kind of culture, you did obviously more on calls, but you had more consistency and continuity with the same team. So in that kind of thing, if you're an F1, you'd be with the same SHO and same registrar and same consultant constantly. So you build this firm structure, this kind of family, and you've got your inbuilt mentors right there. Now, you might be lucky if you're working with the same guy for like 4 hours in a shift. It's constantly changing. So where are your mentors? As a doctor, facing all this trauma and crazy stuff that a 24-year-old is seeing, right? If you compare a 24-year-old on the street, they're not seeing what we're seeing. Right? And where's the mentor? There is no mentor.
You know what's crazy? Have you guys like gone home after a long shift and like have just think back to your craziest shift you've ever done in hospital, have gone back home, spoken to a friend who has no knowledge about medicine whatsoever in terms of what we do, or a family member or anybody, and they just look at you like, what the hell? Like, you know what I mean? Like, sometimes they just think to like, you're thinking to yourself, because sometimes we don't deep the fact that we work in a career which is high trauma, high pressure environment. We don't really think about it. We don't internalize it. But when you speak to other people that maybe do other sort of in other sectors, you really understand, and you basically end up finding out that, wow, I'm in a sort of like, what I do is not normal.
Bro, I mean, my ex-girlfriend, I'll say about over 3 years ago, she was a fashion journalist, all right?
Okay.
Nothing to do with medicine. She had no care or concern for anything scientific or medical. I was an SHO back then.
Yeah.
All right. I was surgical SHO, trying to get my numbers, trying to apply for like ST3, a registrar interview. So applying for all these jobs and very stressful period of time in my life. I would finish work and I would complain to her about, oh, this nurse said this, or this, my boss said this, or I didn't get into theatres today. I was just stuck on the wards. I was doing this, complaining about all these little intricacies in my life. And she just didn't get it. And it's not her fault because she's not in medicine at all.
Yeah.
But I couldn't vent properly because the person
Yeah,
had no
man.
empathy or understanding towards my plight. So you need some people around you that just get it, you know? I'm not saying you need to marry a doctor or go out with someone in healthcare, but you need people around you, like, you know, you two can chat to each other all the time. You need that support network where you complain and they just get it.
100 agreed, 100%, man. So that was actually very, very good insight for us, and you know, it's good sometimes to understand the importance of debrief and the importance of discussions. We wanted to do something. This is how we wanted to start the podcast. So we saw something on your TikTok account which we thought was genius. It's like a video of where you're sort of translating medical jargon into layman's terms, and we thought it's very, very beneficial because, you know, as doctors you study for 5-6 years medicine, and then you're working for another 10 years or so, and you start to lose grips with what people understand or they don't understand. You end up and people will look at you like you're speaking gibberish in another language. So we had a set of sort of different words and terminology, medical jargon terms, that we wanted you to sort of as quick as you can just translate into layman's terms.
So how many terms can you get through in 30 seconds?
we won't set a time limit. We'll just get through the number of words that we have, and then we'll see from there. We'll take it from there. So we'll start off. The first one's lesion.
There's a lot of different things it could be. I would say abnormality.
Excellent.
Syncope.
Faint.
Manipulation. So like an ortho.
Yeah. I would say realign.
Hematoma.
Collection of blood.
Incidental.
Unexpected.
Priapism.
Sustained erection.
Embolism.
I want to say blood clot, but it wouldn't be technically accurate. But we'll say blood clot because that's what everyone will understand.
Yep.
Pouch of Douglas.
Cavity between the rectum and uterus.
Anastomose.
Joined together.
Stricture.
Narrowing.
Strangulated.
Squeezed and trapped at the same time.
Done well, man. That's pretty good. You've been practicing, huh?
Go through cheese and onion. Just reading. No, but you know, you got more?
No.
I was gonna say, see, when I started as a doctor, I would just use all these words. But then when I got into surgery, and increasingly what I have to do is I have to obviously consent patients for surgery. That's when I realized a lot of these patients who had already been consented. So what I would do is on the day, some patients are already consented by someone else in the clinic, okay?
Yeah.
And then I will reconsent them on the day, as in just check, do you want me to go over it again? They'll be like, yeah. Oh, okay, fine. I'll go over it again. And these guys had no clue what had been going on. Because clearly whoever had consented them had used medical jargon. So, you know, instead of saying blood clots, they'd use, venous thromboembolism. You know, and instead of saying, they said for a gallbladder operation, CBD injury. What does that mean for the patient? So I said your biopipes could be cut. Okay. And you're just simplifying things like that. Instead of saying MI, you say heart attack. Instead of TIA, you say mini stroke. And I realize, and there's actually research suggesting this as well, if the patient satisfaction is improved pre-op and perioperatively, it improves their post-operative outcomes in terms of improved recovery, better pain scores, all these things. So actually, let's focus on the patient satisfaction in terms of their comfort levels, anxiety levels, and the understanding of what you're going to do, and they'll recover faster. There's plenty of research suggesting that, and that can be improved with just improving their health literacy. It makes sense, right? Medicine is a whole nother language. It's a mixture of Greek and Latin and all these other things. So it's great for us to communicate. If you're speaking to someone in Greece or someone in Tunisia, and you might not speak the same English language, but you speak the same medical language, they'll get you. You know, anastomotic dehiscence, they'll get that. It's come apart, the bowels come apart. But if you tell that to a patient, they won't understand. But you can say your bowel will leak, they'll understand that. And for me, that is one of the most important things. Patients understanding what you're talking about, so they're confident in your management plan and they're more compliant with what you advise.
I think that's very important. It's pivotal. I feel like throughout medical school, obviously we get those final year OSCEs, you get examinations, and they really hone in on your, especially our university, they really hone in on your communication skills. But I still believe, like, unfortunately, a lot of doctors come out on the other side once they start working, and they sort of go backwards when it comes to the communication. I think they don't really work on, even for myself, without pointing the finger at others. Like for myself, we really struggle with sort of that, like, like trying to tell the patients exactly what's going to happen, what their diagnosis is in layman's terms, rather than, we use a lot of medical jargon. So I think it's very important. And do you reckon that maybe surgical, or I'll say surgical SHOs or registrars, due to the fact that they're consenting a lot of patients, do you reckon they probably have a lot better skill in terms of, like,
Yes and no. I mean, for me, like, there's still a lot of surgeons I see will use the same medical jargon because they're just so used to saying, you're going to have a bio leak, this, and this. And one thing is, simplifying the jargon into English speak rather than medicalese.
Yeah.
But also it's explaining what that actually means. I can tell someone, okay, your biopipe might be injured, but still they don't have an understanding of what that actually means and how that's going to impact them. So for me, what I do is when I consent patients or discuss things about post-op complications or about what their surgery will entail, I'll draw diagrams. Whether someone can speak English or whatever, they can understand a diagram. I used to work in a hospital that the surrounding area had a very large Nepalese population. Okay, and a lot of them were very elderly Nepalese patients, and they didn't actually speak a word of English. And for me, I found it very useful to draw diagrams. When I used to be a medical student in London as well, lots of these hospitals, the patients that come in, they just speak Punjabi, Urdu, Hindi. They don't speak, any English at all, and there's no translator. And you draw a diagram, they just get it. Other things would be a combination of drawing diagrams and just kind of almost pointing out on them and just taking it slow. I mean, it's almost a bespoke management for every single patient. You might come across like a paramedic who gets a bit more of the lingo. So for them, actually, it might be undermining them or patronizing them if someone who's healthcare oriented, if you then start to simplify it too much. Maybe they want the jargon, so they feel respected, like, oh yeah, I'm a doctor too, or I'm a nurse, give me the jargon. So you got to take it, play it by ear.
100%. I think it's all based upon becoming a well-rounded communicator. I think a lot of the times the med students are stuck in their own bubble, digging their heads in the books. But I think the fact that Dr. Karan you've had a great exposure to the actual lay public. And I think that's more so due to your presence on social media, because the fact that you're able to get reactions from so many different people. I think the term you mentioned, medicalese, how many doctors have actually even processed the fact that what you're speaking is actually a different language? And the fact that you can reach out to millions of people, get that feedback, optimize your communication skills in that way. I think that's also something.
Yeah, like that video, that guy, when they were like, oh, what on earth does this say? And he had it on the screen. It was like 77-year-old male complaining of shortness of breath. And then there was another chap, and he was literally translating it.
Yeah. He's like, SOB means son of a.
He completely changed it. It was funny.
That's crazy, man. So yeah, we know you've had an abundance of experience, and you graduated from Imperial, putting in the hard yards to a registrar training, lecturing in Sunderland as well. So you had abundance of experience. Just to go back to when you first started in the NHS, what was your welcome to NHS moment?
Oh man,
that reaction says a lot. I think everyone has the same reaction when you ask that question. It's like, oh man.
Listen, you go through 6 years of medical school or 5 years of medical school, and you start on the wards. You're confident. You've learned all this anatomy for your finals. You passed your finals. You feel, I got my surgery, got my medicine, whatever. Bring it at me, right? You're confident. Got that stethoscope. You got a doctor in front of your name, and you're on top of the world. And you come crashing down just like that. Day one, I'm on elderly care ward. There was a very limited shadowing period, so I didn't really know what was going on. This was like 2014 when the kind of transition from being a medical student to a junior doctor wasn't so well done. Now they've got 1 or 2 weeks of shadowing, and it's a lot better now. This is like bad old days when it wasn't so good. And all the knowledge I accumulated in medical school, when I was confronted with a sick patient who had biliary sepsis, so was developing cholangitis because of gallstones. He was also a hemophiliac, had a bleeding disorder. And the nurse comes to me and says, this patient's got a temperature, he's tachycardic, his pulse is 180, it's abnormal, he's feeling short of breath, he's got lots of abdominal pain, can you come and see him? And I'm like, I don't know if I'm ready for this. I go and see him, all right? And mind you, the consultants in clinic, we've done the morning ward round, just me and the F1. Day one, we've done the ward round. That's insane.
Wow.
The other F1 is covering the other 2 wards on the other side, other 2 bays on the other side, and I'm covering this half. Registrar's on call, and she says she's available if we need her.
Yeah.
He's on call. She's busy as well. No SHO. So just 2 junior doctors, first day doctors, covering quite a busy and sick elderly care ward, acute elderly care ward. I go and see the patient, and I call the other F1. I'm like, Emma, you need to come and help me with this. And she's like, rabbit in headlights as well. We're both rabbits in headlights. We don't know what to do. You learn in medical school the sepsis 6 back in the day. You give some fluids, you take an ABG, you give some oxygen, antibiotic, blah, 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 blah. Just disappeared. And I'm like, trying to look clever and doing this and this. And I have no idea what I'm doing. And I'm worried because I'm not worried for myself. I'm worried for the patient because I'm messing up right now. I need to get him a cannula, give him some IV fluids, give some antibiotics. Easy now to think about what you need to do. It's muscle memory now. It's a reflex. I know what to do. Seen it 1,000 times. Back then, even though I learnt about it and memorized it for finals, I just went blank. So I just went to the consultant. I found him in this clinic and I was like, this is what's going on with the patient. So then he just told me, okay, do this, do this, do this, and I'll come and see you in about half an hour. So then I was slightly more reassured. I couldn't cannulate the patient and I was panicking. It was I spent like 2 hours with that patient. I think I called about 10 different doctors for their advice, the surgical registrar, the medical registrar, I think the respiratory consultant. He was like, why are you calling me? I was like, I'm just trying to call anyone I can right now. And then I think there's about 5 doctors that came and sorted everything out. It was a learning experience for me because I realized I need to shape up fast if I am going to survive here. And thankfully I got better slowly. And you learn from your mistakes. Otherwise, if you don't make mistakes, you're not going to grow. But I had several episodes like that. That was one episode, and the next day, you had like a hematemesis, someone's vomiting blood, and that's like, I didn't expect that. And then it's different things every time. Once you think you've conquered one, something new comes, massive PR bleed. And I'm like, I haven't prepared for that one. Oh man.
Yeah, nice. But I think it happens to everyone, and I think sometimes when you're in med school, you actually you might think to yourself, I've done this many years of placement, I've worked in London hospitals or wherever you are in the country, but there's a difference between you being there on placement and you being the responsible clinician. I think there's it's a drastic sort of change and difference in terms of how you're going to react to certain situations. Because when you're there as a medical student, if anything pops off, or if a patient starts to become unwell, then there's always a senior around. I mean, you're not going to be doing anything anyway. You're just going to be there observing. They might get you to help them do something, but when you're the responsible clinician and you have to now figure out what the issue is, it's a game. And also when there's added pressure, by the way, that's the other thing. So when you're sitting at home and maybe doing some past med questions, or you're doing clinical questions, it's a lot easier. But when you're in time pressured environment and it's happening in reality, mate, it's
I think med school, how they do the curriculum, I'm still thinking back when I was in med school, but it needs to change, and I hope it has, because there's just too much non-clinical work. In 6 years in Imperial, I sometimes jokingly tell people I'm probably one of the first people to do a virtual MBBS, because most of the time I was sat in my room playing Football Manager. Hours and hours, days would go by. Because one time I actually wore a suit while I was playing Football Manager, because I was playing as Arsenal and I was in the cup final. I was joking around. But the thing is, I spent more time playing computer games than actually doing any work. But if I had more time and more clinical time in the hospital, that would improve your decision-making skills, and you see what you're going to be doing. It's not only good enough you just revising it. You need to be doing it.
100%.
You don't have enough of those attachments. happens.
Yeah, 100%. I mean, this is a discussion I had the other day with one guy, one of my good friends. And the thing is, there's you know how now they're talking about making medicine an apprenticeship. I heard there was some talks about it. I don't know, obviously, if they're going to go through with it, but they were discussing it. And obviously, some people are saying, oh, you can't do this. I mean, just keep it standard, traditional. Everyone has their 2 pence on it. But I still think that, you know, there is some element of benefit to that, because medicine can be I feel like it's not just theory. Obviously, you know the theory, but there needs to be a clinical, the application side. You need to be on point with that. You need to sort of know like how to sort of perform in the field. You see what I mean?
Yeah.
And it's extremely beneficial. I feel like, for example, other degrees sometimes have it, engineering and all these various other degrees. And I feel like medicine is very beneficial if, like, you know, if there's an element of that, because you need to be very, very, like, you know, good at when it comes to working in hospitals and the clinical side.
Back in the days, I'm talking several hundred years ago, medieval period onwards, you know, surgeons weren't doctors. Because they were apprentices and they did apprenticeship rather than doing a medical degree. Because this is also back in a time when, you know, the majority of the surgery was carried out by barber surgeons. You know, the barbers who used to extract teeth, they would amputate toes sometimes, they would do, like, you know, bloodletting, all these kind of minor surgical procedures, because, you know, the priests and the monks, who were the kind of physicians, didn't want to spill blood, touch blood, things like that. So the surgeons, as apprentices in those days, they did a lot of practical things, and they were the ones who made progress. You know, like King Louis XIV, right? He had an anal fistula, right? And he had a perianal abscess. King Louis XIV in France, back in the days, he had a perianal abscess.
Yeah.
And he couldn't sit on his throne, and he was in a lot of pain. The perianal abscess burst, and it developed into a fistula. No one knew how to treat this.
Yeah.
Some lowly surgeon, right, found that, okay, this guy's got a fistula. He did experimental surgeries on dozens and dozens of peasants, right, in the French countryside and the prisons. And many of them died from this experimental surgery. He was just figuring out how to treat the fistula.
Okay.
He eventually created like a fistula probe and figured out how to treat it. And he did surgery on King Louis XIV. And that was the basis of coloproctology, fistula surgery.
Wow.
And he started all of that. I was a surgeon, just a lowly surgeon who wasn't like a physician. And it was because of things like that surgeons then became elevated into, okay, you can be doctors now and things like that. So, you know, King Louis XIV's ass was the foundation of you know, perianal surgery and coloproctology. But yeah, we do need more practical stuff.
Yeah.
You know?
For sure.
That's actually mad. You were doing that, so going all the way from that, like, let's say football manager, yeah?
Yeah.
And I think there's a lifestyle element which needs to be considered as well, because that's profound. You had that pelvic surgery, which was lasting all the way from the morning till the evening. That was that must have been crazy. And I think comparing that to the barber and how they used to operate compared to what you did during that 12-hour surgery, that must be very interesting to consider, like in terms of the development of surgery over the years.
Yeah, if you think about surgery over the years, like, you know, it's just, I mean, surgery on its own, it's gone hand in hand with anesthetics and care like that, because without anesthetics, they would do surgery as quick as possible because the patient would be awake. You know, Robert Liston, they called him, you know, the fastest knife in the West, because he would just be as quick as possible. I think
Shankman.
He used to boast that he could amputate a leg in 22 seconds.
Wow.
Right? And surgeons used to compete back then as well. And so, you know, it would be this big amphitheater style thing where people could actually come in and watch the surgeries as like a show, you know, from the street.
Wow.
It was like a event for them. You know, they pay tickets like they're going to a circus, and they'd watch some guy being held down by 4 other guys, little leather strap in his mouth, and the guy would literally go chop. And, you know, this Robert Liston was the same Robert Liston who had this, you know, myth that he'd been involved in this surgery that has a 300% mortality rate. So
wow,
how can you have a 300% mortality
crazy.
rate? So he chops the guy's leg, and the guy dies from a wound infection. And he chops the guy's leg and whatever.
Yeah.
As he's chopping the guy's leg, the assistant holding the patient down, his fingers get chopped off, and he gets a wound infection and dies from that. And supposedly, as the story goes, obviously the crowd are watching as well, there was an elderly man in the front row who was so shocked by what he'd seen, he had a heart attack and died.
Oh my
So
goodness.
that's 3 people died from one operation. But that's what back in the day. So surgery evolved from that barbaric, just being fast. Anesthetics came in, so we could take our time. We could, control the blood loss, and then slowly all of these other medicines come in. Like if you think about, the immunosuppressants we have for inflammatory bowel disease right now, mesalazine and all these biologics that we have. If it wasn't for biologics, the number of bowel resections we do for inflammatory bowel disease would be through the roof. In so many cases, someone who's got Crohn's disease or ulcerative colitis, they're given a course of steroids, they're given a course of immunosuppressants, and that settles the inflammation, and they don't need their bowel removed. So if you think about it, all these medicines have actually prevented lots of times patients having surgery. Otherwise, back in the day, surgeons were just cutting things left, right, and center. They were butchers. They were actual butchers.
So a lot of surgeons now won't be too happy about that, though.
I mean, even if you go back, like, I'm not even talking 500 years ago. I'm talking Einstein days. Einstein had he had a ruptured aortic aneurysm. He was suffering from a abdominal aortic aneurysm for years. He had chronic abdominal pain.
Wow.
And there was Rudolf Nissen, who's also the godfather of Nissen fundoplication thoracic surgery. Einstein underwent a laparotomy, so major abdominal surgery in New York, and they found this big, grapefruit-sized aneurysm, and Nissen just wrapped some cling film around it. So that was one of the first surgical innovations. And they're wrapping the cling film around it, the same cling film that you wrap your sandwiches in. It caused a fibrosis of the arterial wall, and the fibrosis stopped the aneurysm from popping.
Wow.
And that gave Einstein an extra few years. And then eventually it burst and he passed away. But, that's like a crazy innovation to think,
Yeah. I feel like the field of surgery, in terms of innovative ideas and innovation, I feel like the scope of innovation within surgery is endless, in my opinion.
I think so. Robotics.
Yeah.
I've seen in Israel, like they've got this kind of hologram where they can see all the structures, almost like augmented reality, and, do all of that. So, in my lifetime, I don't think surgery will be replaced by robots or anything like that.
Agreed,
But
yeah.
200 years, 300 years, it'll be crazy
Possible, yeah.
It's fascinating, those paradigm shifts which occur. And even if you look at now the likes of ChatGPT and what they can actually achieve, and to be honest, we're all marveling over these barbaric kind of practices back in the day. You wonder what the consent process was like for 300% mortality. Like, okay, are you ready for this procedure?
No consent.
But like,
Just get on the table.
imagine if they're laughing at us, like what kind of surgeries we used to do. Like, oh yeah, you guys actually did Whipple's procedure?
Barbarics. I mean, some of the general surgery is still one of those fields where I would say out of all the other surgeries, it's still, you could say, one of the most barbaric. We're cutting people open down the middle, opening them up like a suitcase. We're removing large pieces of colon. We're removing their esophagus, their stomach, and their pancreas, most of it, all these kind of things. Yeah, maybe in 100 years' time, people will laugh back like, do you know what Dr. Karan used to do? Or even things like, chemotherapy. Yeah. It's like a life-saving medication treatment agent for a lot of people, but obviously it has significant, profound side effects. And in 100 years, they might be like, people, chemotherapy? Because, chemotherapy started out as a chemical warfare agent. It's derived from mustard gas. It's like a derivative from that. And they showed that it reduced these tumors in mice. And then they thought, okay, let's test it in humans. And that's how it all started. And obviously it's not mustard gas, but it's a derivative of that. Okay. And obviously they say that war is the trigger for lots of these surgical innovations. But it started from that. So, it truly is barbaric if you think about it. It's, a warfare agent that was used to kill people, and it was modified to then treat cancers.
Wow.
It's actually crazy. I think we've learned already on this podcast, Dr. Karan, I would consider you as a jack of all trades. And definitely, obviously, you have knowledge into all these different fields, which I think is amazing. And I think that as medical professionals, we should actually have that, not just life as a whole, but within medicine, we should pride ourselves in having knowledge of all these different affairs. Having said that, though, do you get interesting questions from the general public expecting you to answer there? I know you do a lot of myth busting, and that's the topics kind of we wanted to touch upon now. What's the craziest DM which you've got?
You don't even want to know. Listen, I've had DMs of people sending me like, of their CT scans and whatever. But I've also had DMs of people, you know, sending me pictures of their intimate areas, of their hemorrhoids and all sorts of things. Or like, you know, my...
What did they send you? Like, just take a picture and say, can you resect it, brother?
They'll literally take a picture of their penis and be like, what is this rash? Or like, you know, and it's thing is, right, besides that invasion of my eyes, it's like you know, they're not doing proper service to themselves, because if they're waiting for someone online to tell them, they're delaying actual medical treatment they might need from going and seeing someone face to face. So I tell people constantly, I can give you generic health advice. I can talk about topics which might be of interest to you and your specific condition. But I can't give you advice about your personal medical condition. It's not fair on me. It's not fair on you, especially.
Maybe this is a possible, though. Maybe this is a possible idea, like possibly like someone could start up, like, because a lot of people, you know how now we're living in a society where everybody wants things quick. Nobody wants to wait. Like, even people, the same people that DMing you could probably, like, you know, jump on what's that thing, GP thing, Babylon or something. I could probably like get into contact with like a private GP online or something, and they could send it just as quick. But like, you know, it's people want things done very quickly, so sending you a DM is, you know, it's a lot easier for them.
I think it ties into people buy into the persona and they trust you, and I think that's a big element in medicine.
True.
Like,
that's true.
Obviously, we both come from a Asian background. Zakaria, Somalia as well. We know what it's like. As soon as you get the MBBS, the phone calls start coming in. The aunties and uncles, okay, what's this? Even for the most trivial affairs, like, okay, can you give me a diagnosis? I can only imagine what it's like on your scale with a large
I mean, the thing is that they learn very early on. Like, when you first graduate, you get that, you know, like a big flood of like, oh, what's this? What's it? Can you help me with this? But then eventually you got to phase it out. And then, so right now where I am, like, you know, almost a decade in, I don't get bothered too much by family. Obviously, like my parents, I'm always going to help them with whatever. But there's only so much you can do, because out of hours, you do want to switch off as well. You're not a doctor practicing 24/7. You need some downtime where you don't think about medicine, you know?
For sure, man.
That's part of your, you know, like TLC, you know?
100%. Dr. Khan, what are your thoughts on cancel culture? I know that's very popular in social media nowadays. And to be honest, you're in the field of debunking many myths, right? And there may actually be other medical professionals. And sometimes these things can have like a spectrum, like people are on different ranges of the spectrum with regards to different subjects. And it may not be a black and white area. So how do you deal with like criticism and things like that? And how do you navigate generally the cancel culture and making sure that your facts are scientific? I know you once, there was a recent video from Dr. Mike as well. And it's like, you know, it was some kind of clickbaity title as well. We must stop this doctor or something like that. But obviously he was, in the actual video, he was in support for you. So what are your thoughts on that?
You know, I mean, cancel culture is so rife nowadays. All you need to say is one wrong word without even meaning it, and someone jumps on you. A bunch of people jump on you, right? Because people enjoy watching other people being taken down. It's human nature. Why did the Romans used to love gladiators, you know, fighting each other and fighting to the death? Because they love combat, you know. And the modern day gladiators is people beefing on social media, you know, people saying, oh, let's cancel this guy, let's cancel that guy. That's culture we're going towards. We've always enjoyed that animosity and that fight, and that's never going to go away. That's just part of human psychology. For me personally, how I navigate that cancel culture, like you said, any video I'll put out, I'll make sure it's scientifically accurate. It's within my wheelhouse to a certain extent. You know, if someone asks me, you know, some specific level, a specific question about the treatment of congenital cardiac conditions, and ask me to give like a lecture to a room full of cardiologists, I'm not going to do that, am I? Because I'm not a cardiologist and I don't know that much in detail about congenital cardiac condition, tetralogy of Fallot and all that. So I think you need to understand your limitations, make sure as much as you can things are accurate and scientific, and do everything, you know, in earnest. But at the end of the day, I feel that, you know, you can only cancel yourself to some degree. You know, if someone says something against you, and then if you try to, you know, take a defensive approach and you hide behind that, why are you hiding? If you've got nothing to hide, you just be like, okay, whatever, you can shout all you want. you know. But if you just keep doing what you do, it's behind you. And if you see lots of these creators who are cancelled, they eventually just come back. You know, people have got very short attention spans on social media. You might be cancelled for like a month or 2 months, and then you eventually just come back, and people forget all about what you've done.
Yeah.
Amazing.
Yeah, there's a lot of sheep as well. I feel like, like maybe it's due to the fact that people like to, see other people being taken down, and they like to see like, people fighting each other on online presence and social media. But there's a lot of sheep. So as soon as one person like, maybe tries to cancel one person, then a lot of people in support of that other individual who wanted to cancel. So I don't know. It's just stuffed.
It's human nature to not only enjoy combat, but also to enjoy sometimes other people's misery. Schadenfreude. You enjoy the embarrassment or the misery or the negativity of someone else's life. And even the most well-intentioned person may occasionally enjoy that. Oh, so and so lost out on that. You feel a little bit happy. And even the nicest person might sometimes just take a little bit of pleasure, or not maybe pleasure, but just it makes them feel good that maybe someone else hasn't risen up a little bit, in relation to their life. It just validates them, and okay, I'm still okay. He's not gone so much above me. It's human nature, but some people actively enjoy someone else's suffering and misery.
100%. I mean, that's obviously, there's pros and cons to the meteoric rise of social media within the recent last few decades. But with regards to the pros as well, obviously there are a lot of lucrative opportunities, and I'm sure you're no stranger to that with regards to different sponsorship deals and different potential avenues which you could have taken, but obviously you've decided not to, and things like that. With your current position, why isn't that you haven't left yet? As many people within the current limelight, we have seen examples of people doing that. Once they reach that level, they've actually left and they've adopted for a different trajectory in their life.
I mean, I still very much enjoy surgery. I enjoy working with other people, and doing what I do still brings me joy. There's lots of downsides, and it comes with a lot of stress, on calls, night shifts. That stuff's not nice, and I wish I didn't have that in my life, but unfortunately I need to do that so I can still continue to operate and see patients. Having said that, if I completely left the NHS and went fully into kind of social media, there's a couple of things. I would miss surgery and miss, my hands would get rusty and I would be itching to operate on someone. But also I think you are no longer current, in terms of you lose sight of what's actually going on. You don't have that, your finger on the pulse anymore. And you lose a degree of credibility as well if you're not a practicing doctor, I feel. Being a practicing doctor provides you with a certain level of authority and knowledge and awareness of what's going on, so you can talk about that. But if you're just almost like a TV personality, you become almost overproduced and you're not authentic anymore. That's what I feel. And also, listen, there are no shade to anyone who's a medic and taking all these paid opportunities, but you need to be very careful. And that's my lesson to anyone going into that world. Be very careful of what you align yourself with, what sponsorships you take, because a lot of the things we do, this podcast that you do, my social media that I do, a lot of it, the goodwill that we have is based on our reputation and credibility. If you ruin that by suddenly promoting CBD supplements or something like that, your credibility is down the drain, and everything you worked for, podcast or platform, it goes. So that is the kind of dark side of social media that doctors especially need to be wary of.
I think that's commendable, the fact that you have certain principles and you abide by them, and you ensure that you're not swayed by whatever they dazzle in front of you. I think you won't get too many individuals in this current day and age like that would sort of stand by their principles. A lot of people are just swayed by the money, by the fame, by other things, so we really commend you for that. I was going to ask a question alluding to the fact that you mentioned obviously now you are still a practicing surgeon, and we know, being hospital doctors, we know what comes with like a busy rota in hospital, the on-calls, the night shifts. How do you balance working as a surgeon, registrar, working within the NHS, and we know how hectic it can be, with obviously your social media and your extracurricular activities?
Yeah, I mean, as with all things, it's about finding some balance between being productive on both sides. I've got a great opportunity where, I've got a nice platform on, several social media pages, but also, progressing in my career. I wouldn't want either of them to slow down or go backwards because I'm focusing too much on one. At the end of the day, if you told me that you had to choose one's got to fail, I would pick the social media to fail and let me be a surgeon.
Yeah.
That's what I've worked my entire life for. I've been on social media for a few years, great, since 2012, but I've always seen it as a hobby. I still sort of see it as a hobby.
Yeah.
It's a thing that if it completely disappeared, yeah, I'd be disappointed because I worked hard and I enjoyed doing that. But my real sort of calling, as it were, and the thing that I've spent so much money in the career, pouring into a surgical career, training, nights, all that, and my parents are happy that I did this, is surgery. I genuinely enjoy that. But I think finding the time is, you get the odd days off, you get weekends off, and it's being very productive. And just saying, listen, between 9 a.m. and 11 a.m., I'm going to record 2 videos. And that 2 videos will last me a couple of days. Or it's like, you go on a podcast with someone like today. And okay, the podcast is an hour long or whatever. You got a few clips and that will last you for a few days. You make a YouTube video that's an hour long and that can last you for a few days. It's just being very clever with what you do, because making new content every single day, that's not sustainable.
Yeah, you have to be proactive.
Yeah.
Very commendable. I do appreciate that. And you mentioned that this increases your passion for the actual work which you do. And obviously you must have been remembering why you started, such that this actual hobby which you have doesn't overtake the primary thing. That's very interesting. But Dr. Karan, you had alluded to a can of worms earlier. I don't actually have a can of worms right now. I just have this bottle. But I think I'd really like to kind of delve into this in more detail with regards to the NHS and the current environment, current affairs which are occurring. There's obviously well-known junior doctor strikes are occurring. And just wanted to ask you, like, with regards to the struggles which the NHS are facing, why are the doctors leaving the NHS?
I mean, there's so many reasons, right? I mean, I think one of the most galling statistics that I've come across is that a barista who works at Costa Coffee is earning £14 10p an hour. A first-year junior doctor is earning £14 9p an hour. No offense to any baristas out there, but I would expect someone who's doing a 5-6 year medical degree and is then becoming a doctor to maybe be on more than £14 9p an hour. And the progression isn't significant after that as well. For many years, you're working at, in the teens per hour in terms of your remuneration, £19 per hour, things like that. Aside from the money, I think also what is important to acknowledge is actually the working conditions are terrible. Junior doctors that I've spoken to, it's not just me, I've undergone this, and you probably have undergone this as well. At many points in your career, you're infantilized by other specialties and other healthcare professionals. You're humiliated, you're undermined, you're spoken down to. You're not respected for your work. An example of this is, you do 10 amazing things that you go above and beyond. You don't get a thank you. You make one minor error where you're late or you don't get it done on time or something, you get completely admonished for that. So you get caught up on maybe a slight slip up, but when you do the good things, that's not rewarded. So it's all stick, no carrot. And I think it's a combination of poor pay, it's a combination of poor working conditions, and just a very toxic culture. And this stuff can really play with your mental health. And especially with the pandemic and the amount of work that we had to do during the pandemic, I think that just was the last nail in the coffin, and people are just fed up. And they just want more respect as well.
I mean, it's all of those years of training, and to be honest, the actual impact that it has, no matter how someone says it, how much someone says it, I think only the people who actually do it can actually realize, like, it's just crazy. Because some days you come home from work and obviously you have a family, right? And the constant variable tends to be your family, because maybe they haven't necessarily been to what you've been through, and then you're just realizing how is my behavior changing today compared to yesterday? What is it that's been through? And sometimes you're just going home and you're trying to dissect, like, why is this occurring? Why is that occurring? Like, what have I been through in the last 4 days that caused this? I'm just wondering, is it that person who spoke to me in this way? Is it that patient I saw? Is it that end of life scenario which I was dealing with? And you just don't know where to start at the end of it. And it's like, you could have done that without 6 years of training, and obviously you put blood, sweat, and tears for that training as well.
When I was a SHO,
Yeah.
I used to work, I won't name the hospital, but it was an island hospital off the mainland, all right? And for 3 months, I didn't realize, but I just wasn't getting paid. And I called them. I was like, what's going on with my pay? And then they said, oh, someone made an error when they were putting in your sort code.
That's ridiculous.
So I was like, so someone else has been getting my pay.
Yeah.
So they eventually sorted that out after some time.
Yeah.
And more recently, in the current hospital I'm working in, they're paying me £8,000 less than I was being paid last year because they've messed up my grade.
That's
so they're
crazy.
paying me at a lower grade than my current grade. And I picked that up on my tax forms. I sort of complained to them and I was like, can you sort this out? And they said that payroll said, you need to speak to medical education. They need to send an email to us. I can't get through to the medical education person. So I'm going round and round, just trying to get the money that I'm owed.
Yeah.
I'm like, give me my money. Give me my money.
That in itself is a locum shift, because sometimes when I'm owed money, right? And I'm thinking, how much is this money? If I spend the time chasing it, could I recuperate that by just doing a locum shift and actually getting that money? Like you're chasing this, like, let's say 12 hours, in totality. And you're like, could I have just done a locum shift and just ignored that,
what I mean?
taken the L?
And the thing is, right, all this, so listen, one part of the job as a doctor is, doing the ward round, seeing patients, operating, all these kind of things. That's one part of the job. Another part of the job is career progression, where we have to do the logbook, we have to do online portfolios, all this stuff. That stuff we need to do in our own time, even though it counts towards progression. So if you don't have an up-to-date portfolio with, X number of work-based assessments or whatever, you can't progress to the next grade. So that we should have allocated time during the week in the working hours to work on that, but we don't. You got to do it when you go home in the evening, blah, 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 blah. Where's the fairness in that?
There's another thing I wanted to also shed a light on, was the fact that obviously you might have encountered this more as a surgeon, but sometimes it happens where you might leave 2-3 hours late, but obviously when you're a surgeon, sometimes the operation might extend like 6 hours, you don't know. How difficult is it to get that time that you're owed? How difficult is it to get back, either in annual leave or in sort of financial recompensation? So
it's difficult because, like you rightly said, when you're doing surgery, you know that you're not going to have a 9-to-5 job. If I'm in the middle of a major operation and it goes 5 p.m, I'm not going to put down my scalpel and walk out of the operating room with the patient's abdomen and intestines poking out. I can't do that. And I wouldn't, ever think about something like that. Although there's another story. I know I have a story about a surgeon who did something similar. But, I think if I finish like 5 hours late after one surgery, depending on the hospital I'm working in, I might have a good relationship with one of the bosses that just understands that, you stay late one day, and if it's quiet the next day and there's enough cover, you leave slightly early and you make up the time that way. So one day I finish at 7 p.m, another day I might leave at 3 p.m. You kind of make up the hours that way. That's how I see is fair. But, in some hospitals, they might not like that. They might just be like, tough. You wanted to, do that, you got to stay. You got to stay till 6 or 5 every day.
What's interesting is that boxing as a sport, they're actually paid quite a lot, especially at the higher end of things. And a lot of people will give the argument that, okay, they're sacrificing themselves, they're putting their body on the line, perhaps even impacting their health. And now think about doctors. I mean, first of all, night shifts can be considered as a carcinogen. And generally, it's understood scientifically that essentially you're reducing your lifespan, you're putting yourself at risk of different health conditions. It's just looking at the fact that you're actually like putting yourself at risk to health. I would say like there is a comparison between obviously all of those high risk environments, boxing, things like that. But in the medical field, it's actually understated what they're putting yourselves into.
I've constantly said, when you're being a healthcare professional, when you're being a doctor, you are reducing your life years in exchange to extend other people's life years. You're putting yourself at risk in every facet of the body, every system in the body. So when you're sitting down for 2 hours working on paperwork, your musculoskeletal system is rubbish because they're not giving you proper ergonomic equipment when you're working. When you're doing the discharge summaries or the paperwork, you're just using old systems, and they don't have the proper wrist rests, carpal tunnel, bad backs, the chairs are terrible and half the time they're broken. The table's not at the right height. When you're eating in the canteen, clean. There's no nutritional value in that. So obviously your gut is affected as well. You get, gastritis, diarrhea, who knows what's in the food, and there's no, proper nutrition, doesn't fill you up. Like you said, the night shifts as well. You have poor sleep. And then we all know poor sleep affects every body system from, your brain to your lungs, to your kidney, to your bowels, to your heart. It's being a doctor is not conducive to often good health, particularly if you're doing on-call shifts, unsociable hours, night shifts. It's just, it's horrible. And like rightly you said, it's a carcinogen. There's lots of studies which suggest that healthcare workers have a reduced overall mortality compared to non-shift workers. I would say I had a sick meal the other week, right? There's some Kerala chef working in the canteen. And one day I came down. I normally I tried not to get something from the canteen unless I'm starving. I came down, I was starving. And looked, they had chicken biryani. And I was like, it actually smells good. And it looks good as well. I still wasn't buying it. I asked the guy serving, who made this? And he said, oh, Polly made it. I was like, who's Polly? Show me Polly. And then he called out Polly. This is Asian dude. And I was like, where are you from? He's like, I'm from Kerala. Yeah, this is like Kerala chicken biryani. And I'm like, all right. I tried it. 8 out of 10. Solid.
Amazing.
Yeah. Because it was cheaper than the normal stuff and it would tasted better. So it's probably like not good for the NHS to do that. So yeah, I don't know. But I need to get that guy's number, do some private cooking for me maybe. Yeah.
Yeah, so you don't have time. It's like probably they think that you don't have time to go canteen, chill with the biryani. Like you get back to work and you don't have time for that. Sometimes you're prescribing IV fluids and you're like, when's the last time I had a drink? You're like, wait a minute. And it's actually crazy. Did you actually did your sleep problems which occurred? Obviously, it's well known on online. You've documented that. And was that caused by the work, do you think?
I think a combination of work, but also balancing work and life. I found myself often when I was at F1 anyway, first year doctor, bringing some of the work home. Like I mentioned, seeing patient deaths and these traumatic scenarios, maybe not properly processing it from an emotional standpoint, just not juggling life properly. These early starts, late finishes. And see, increasingly you find balance at work. You know that at 5:30, if there's not an emergency going on, you wrap up, hand over and leave, because you need to have a quality of life and you need some sort of boundary between work and life to actually function as a human being. But I didn't figure that out yet as a first year doctor. So I was finishing at like 8 p.m. and the night person would be like, why are you still here? You could have left all of this to me. And so I didn't fully appreciate. There was shifts where I would be there till from 7:30 in the morning till 8 p.m. I'm not even on call. So you learn that, and that all those kind of things, and that lack of regulation and balance affected me. Not having someone to talk to, like a mentor. Eventually found a mentor, and we kind of spoke about some things. He helped me with like just my career, my interviews, all these kind of things. And occasionally you meet people in the NHS who just make a massive impact on you. Hold on to them and keep them throughout your career. Even if you go into a different career, you hold on to them. There's a urologist, a urology consultant that I still talk to now. I obviously don't do any urology surgery. I'm not a urologist, but still keep in touch with him because he was a mentor for me when I was an SHO on urology. He gave me audits to do. He gave me publications to do. He just generally, gave me some coaching and took me under his wing. There's certain people like that. It's worth, just from a platonic point of view, like a friendship point of view, you just keep in touch with them. It's so rare and far and few in between in the NHS that you get people that you're just like, you're a good guy. Life. I'm glad to have met you, kind of things. Keep hold of them.
Especially if they're urologists and you're on surgical night SHO cover and you need that input, you take your referrals and stuff. No, but it's important. You're right, man. You need that mentorship, man. It's something me and Inam always talk about, man. Like you need that guidance, These sometimes you meet individuals like either within your specific desired field or career that you want to get into, or what specialist route you want to go down, and you need that guidance, man. So it's very important, and I feel like this is another thing. I don't know whether it's due to lack of time or maybe lack of awareness, but us doctors, healthcare professionals, we don't do a lot of, and even just in life, to have like a mentor and have a person you look up to, and you have that guidance is extremely important, man. So Dr. Karan, we're heading on to the ending of the podcast, but before obviously we wanted to sign off, we wanted you to tell us this is something that I always think of, when I see like a lot of like different people that maybe, like for example yourself, and I see you that you do a lot of like debunking of health myths. What's the most unusual like health myth that you looked at and you thought, wait a minute, but you still obviously went through and you educated the people and you debunked? What's the most unusual thing you've come across?
There's so many. I mean, a couple of things relating to what I do with kind of, general surgery is people seem to be obsessed with thinking that their intestines are populated with parasites, worms and tapeworms and things like that. And they recommend all these cleanses for them, all these, anti-parasitic agents like Paragard, or that people think that they need regular colonic cleanses to detoxify their liver and colon. And I just don't understand that. I mean, your body is great at homeostasis, keeping everything in balance so it can take care of itself. And I'm thinking like, if you're taking all of these herbal supplements and all these things to kind of detox yourself, you don't know that all these, even herbal supplements, are drugs. They're chemicals, and they can have interactions in your body and all sorts of things. They can, make your blood thinner, or they can interact with other drugs that you're taking. I think for me, basically, colonic cleanses, in that, you go somewhere, someone puts like a pipe up your ass and they flush it with like saline or water to flush out all of these things. That is incredibly dangerous. I've been involved with a case a few years ago where someone had hydrotherapy, like some sort of colonic irrigation, and they came in with a bowel perforation because the jet of water perforated the bowel. They had thin bowel. It was an elderly patient, and they had to have a laparotomy and a bowel resection, and a stoma formed, a feces bag on the outside because of this colonic irrigation. And after talking, the patient was on the ward for weeks. And they said they'd, found out about this online, this colonic irrigation to help with their constipation or something.
Are doctors telling people this is okay? Like who?
I don't know if they're doctors or just some sort of, nebulous medical practitioners
Gurus.
that they claim. I don't know who they are. And that's the thing about social media. Often you don't know who anyone is. I mean, I technically, could be a fake doctor. If people didn't know me, around, I could, all I need is a stethoscope. I can wear some scrubs and just talk. I could call myself, doctor, whatever, and I could just say stuff online. People would believe you, right? How are they going to check you?
Yeah. That's why trust is important. That's why you get all of these intimate pictures, man. Because they trust you.
Yeah, trust me too much.
So just before we finish off, obviously we're just going to announce your final few projects, new projects which you have. And I know we've talked about the different challenges that are associated. We wanted to finish off. I know there's perhaps a low morale currently, especially within the junior doctors. A message of hope and a message of motivation for the junior doctors. Maybe even some motivation for, things will get better, and motivation for change. So do you have any kind of final messages that you'd like to share on this platform, be that for the government, or be that for the working doctors sacrificing themselves day in, day out? Any just final messages on a more positive light?
I wish I could be very positive and tell you things will get better. The honest answer is I don't know. But what I will say is that, if you're a doctor, you have already undergone so much to get to that point. You are an improbability. You have beaten the odds to become a doctor. You've gone through so many exams, even before that, A-levels, GCSEs, or whatever you've gone through, and you've gone to become a doctor. You've got an incredible amount of knowledge, which a lot of people would be jealous of you for. You're an incredible, noble profession. And all I would say is, this is a general kind of philosophy that I follow in life. Your best days and the best moments in your life are yet to come. As a junior doctor who's 24, 25 years old, you've literally got your whole life ahead of you. So if you've enjoyed some moments in your life, just think ahead. You literally got some of the best moments in your life haven't even happened yet. So that's something which, fills me with hope sometimes when I just think I'm having a really rubbish day. And I just think, it is what it is. The next day might be even better. So each day, you're not looking to suddenly be the best doctor in the world. This might sound a little bit crude, but you're just looking to be slightly less every day. That is what I try and do. And the next day, if you are even worse than the previous day, that's fine. The next day, try to be a little bit less shit, a bit less rubbish. That's it.
Profound, amazing, man. I'm gonna have that repeat every morning.
These are the kind of clinical supervisors you need, huh?
yeah.
Legit, that's all you need. Mate.
100.
Spell it out for you, clear terms.
it.
Huh?
Yeah. Thank you very much for coming onto the podcast, Dr. Karan. Before we end off, you've got some exciting projects coming along that you'd like to announce exclusive.
Yeah. So it's something I've been working on for like over a year now, and I've got a book coming out.
Wow, amazing.
It's going to be published at the end of the year, but it's out. You can pre-order it, and yeah, I'm excited. I mean, it's probably the biggest thing I've ever worked on. I mean, I've never written a book before. I've only written scientific publications, and this was a whole nother beast. But I'm really proud of it. Like, it's exactly what I wanted to write, and I hope if people want to read it, that they will enjoy it and love it as well.
Yeah, we'll definitely purchase one for sure. Show our support.
100%. It's all about getting to know someone in depth and gaining understanding of their wisdoms in depth. And nowadays, we have the rise of short form content, but we cannot underestimate the power of books and the power of what you can take away and benefit from learning all that you've experienced from your entire journey, right from childhood. And that's absolutely amazing. I really look forward to reading that.
Yeah, definitely. So where can they find it? Will be on Amazon or?
Yeah, I'll give you a link, and wherever you are in the world, it takes you to wherever you need to go to get the book.
Amazing, brilliant. And obviously we'll put it in the YouTube description, so definitely check that out, guys. Make sure you buy it, show your support. And from the StriveMed podcast, it was Dr. Zach.
Dr. Anam. You can find us on Instagram, StriveMed, TikTok, StriveMed, www.strivemed.co.uk. Make sure to hit up Dr. Karan Rajan's pages. We have Karan Rajan, all of the links in the description and on the screen as well. And until next time, take care. All the best.
Thank you very much.